Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon, president of RhAPP, and today we are tackling a condition that often flies under the radar in rheumatology, X-linked hypophosphatemia, or XLH. I'm wondering if you've heard of this condition, because I have to be honest and tell you that a few months ago, I had not heard of this condition after 18 years in rheumatology. So I think it's probably something that we often don't think about and potentially are missing. XLH is a rare hereditary disorder that can mimic many common musculoskeletal and rheumatologic conditions, which can lead often to a delayed or missed diagnosis. As rheumatology providers, recognizing these red flags early is really crucial to ensure timely intervention and better patient outcomes. Joining me today is Bonnie Smeryage, DNP, who will help us unmask this often misdiagnosed condition, discuss key clinical clues for recognition, and explore strategies for management. Bonnie is a paid speaker as a member of Kyowa Kirin Speakers Bureau, and this podcast was developed through a collaborative educational partnership between RhAPP and Kyowa Kirin. Bonnie, for those listeners who haven't been lucky enough to meet you, can you give us an introduction?
Sure. First, let me just say, Amanda, thanks so much for having me. As she said, my name is Bonnie. I'm a nurse practitioner in sunny South Florida at Joe DiMaggio Children's Hospital in pediatric rheumatology. My background, I spent 10 years doing pediatric nephrology, and then I kind of began my career in pediatric rheumatology and have since fallen in love with it. I am passionate, just like all the rest of your listeners, about the patient experience, improving medication adherence, especially in our most challenging disease states. And believe it or not, I love working with adolescents. I have one of those at home, so I know how challenging that can be, as well as a really energetic puppy that keeps me on my toes.
Oh, well, we are so fortunate to have you on RhAPPcast and kind of help us understand XLH. And obviously, this is something that's rare, and we really should be familiar with it. So I'm so excited to talk to you today. Also, I have two of those little adolescents at home as well. So I definitely feel it. And I can say it's pretty remarkable that you do pediatric rheumatology. One of our board members is also a pediatric rheumatology APP. And I just think to myself, I don't know that I could ever do that. But we obviously need much more of you. But I'm super interested because, again, like I mentioned at the beginning, I really didn't know what this was until fairly recently. So tell me how you kind of developed this interest in this and, where that all came from.
Yeah, so I have been taking care of XLH patients for over 10 years. We at Joe DiMaggio, typically you'll have pediatric nephrology see the patient, whether they start in genetics or in endocrinology. And then that kind of followed me here into rheumatology. And I think rheumatologists really are at a perfect and interesting position to be interested in XLH and to understand its symptomatology. As experts in arthritis, I believe that as rheumatologists, we understand the signs and symptoms of XLH that can often really look like arthritis and mimic our really tough RA patients in ankylosing spondylitis and other spondyloarthropathies. And I find that these are the patients that present with worsening bone and joint pain, and they just don't seem to improve on our typical treatments of NSAIDs or biologics. And as the health of the bone directly impacts the health of the joint, it's really imperative that we understand and evaluate those bone minerals such as phosphorus.
So true. I'm so excited to discuss this with you further. So for our listeners, whether you've encountered XLH in your practice or it's still unfamiliar, like I said, it was for me until not too long ago, I think this episode will provide some insights that you really need to know to improve detection and care for your patient. So let's dive right in. So let's just start kind of with an introduction into XLH. So can you give our listeners an overview of X-linked hypophosphatemia?
Sure, of course. So it's a chronic, progressive, systemic, hereditary metabolic disease of renal phosphorus wasting. So we know that it used to be put in this pediatric bucket where we thought that it was really limited to the growth periods. But really, what it is, it's a renal phosphorus wasting defined by abnormally high amounts of phosphorus in the urine. And as opposed to where it's supposed to be, which is remaining in the blood. And so that's what happens is that because of the elevated phosphorus in the urine, you'll get a low phosphorus in the blood and hence the condition. So that chronic hypophosphatemia will lead to that bone mineralization defect, impacting joints, muscles, ligaments, and the tendons. And even though we know that it has always been rare, it really affects 1 in 20,000 individuals. And like I said before, because it had been in that pediatric bucket, we've called it by many other names. We've called it vitamin D resistant rickets, and we've also called it familial hypophosphatemia. But it really is truly known by its real term, which is XLH, coming back to the point that it is hereditary.
Wow. So what actually causes it, and how does that impact patients? And again, why is it misdiagnosed?
So it's caused by a pathogenic change in the gene known as that phosphate regulating entopeptidase. Say that 10 times fast. But really, it's FEX, and that's X linked. So when there's a loss of the function of that FEX, that leads to the increased fibroblast growth factor, or what we call FGF23, which is a hormone, and that is produced by the bone. And when you have excess FGF23, it leads to a decrease in that serum phosphorus by two different mechanisms. And so that in turn makes that serum phosphorus go down.
Okay. So that I'm kind of starting to work my way through. Wow, you're really smart, I have to first say. Um, what other top line items do you think would help our listeners with this kind of conversation as you and I are discussing kind of moving forward?
So I think that one of the main things is obviously identifying the XLH, but understanding that the phosphorus has its footprint in so many different systems in our bodies. And that's really where we get into the importance of phosphorus and not overlooking it. And knowing that those signs and symptoms that we used to think they began in childhood and stopped really progress through the lifespan. And so I think that we know that it can overlap into these other rheumatologic diseases with bone and joint and muscle pain. But actually, like 90% of XLH patients have enthesopathies. And what do we see in rheumatology? We see so many enthesopathy related, enthesitis related diseases and pain as a result of that. And I would venture to say that there's probably a patient or more lurking in every rheumatology clinic that just never improves with those typical treatments. And what do? We change biologics, we do other things, and really we'd like to just check the phosphorus. So that's probably my top line item that I would say is that in my opinion, we can't expect to evaluate the health of a joint if we don't evaluate the health of the bone. And that really gets down to the crux of checking that phosphorus and knowing that anytime someone comes in with bone pain or weakness or early onset osteoarthritis, this could be a sign of XLH.
Well, yeah, the other condition that you think about, right? Like, let's say we do a workup on a patient and we say, oh, you don't appear to have an underlying spondyloarthropathy. Their labs are normal. They don't have the HLA-B27. The x-rays are negative, and then we, sometimes what do we diagnose them with? Fibromyalgia, and so you do kind of have to wonder if potentially even that's a mimic for this. That's kind of what comes to my brain is like, okay, what about those people that we kind of say, oh no, you don't have anything, go about your way, and are we missing that? And you kind of alluded to this already, but what really are the hallmark clinical signs and symptoms of XLH that should really raise your suspicion for this diagnosis in both pediatric and adult patients? Because we have both pediatric rheumatology providers like yourself that listen to the podcast, but also adult rheumatology providers.
Absolutely. So first, usually typically the textbook picture is going to be, either a child or adult with those lower leg deformities, like bowed legs or knock knees. And that would have been hallmark, especially for ones who are diagnosed as child, and as they weight with the weight bearing, their legs will bow like that. But actually, the interesting thing is that disproportionately patients with XLH are of short stature and they have gait abnormalities. So, seeing a patient with these issues alongside those other manifestations could indicate that this is XLH. Additionally, we also have seen patients with poor dentition and also hearing loss, because all of those are even bone related issues, but those might be outliers to what we would typically consider to be bone issues. But even more importantly, the disease has such a wide variability. We have patients that have more of a muted symptomatology. So when I say that there is a wide variety of symptoms and severity, I can't say that enough, because there really is a range from having no visible symptoms to severe deformities.
Wow. And you kind of already mentioned the spondyloarthropathies as one of the things where we kind of change biologics because the person's maybe not responding. What are some of the other kind of most common misdiagnoses that you tend to see or have seen that would give, our APPs clues as to, hey, maybe I really should be checking the phosphorus and putting this on the differential?
Absolutely. So I would say that patients that can present with osteoarthritis and are of young age, that those should have a real strong alarm bell going off in their minds. And then anybody with enthesopathies, back pain, and stiffness are really common for XLH. So any provider that suspects a spondyloarthropathy or a spondyloarthritis, really, there's going to be a lot of symptom overlap. And it could be just as easy as just checking the phosphorus. A fasting serum phosphorus is really going to be the most uh, beneficial in those cases. But anyone with fractures and pseudo fractures are also really common in XLH. Even though, so you would suspect osteoporosis, also you could suspect XLH.
Okay. That's really helpful. And you mentioned obviously this is a hereditary condition. So how important is it that we ask about family history when we're making this diagnosis?
Oh, in my experience, rheumatologists are very well versed in going over the genetic conditions. I mean, that is our bread and butter of rheumatology, asking about anybody that has lupus or RA, and we have such overlap with other autoimmune conditions. So I would say that we really tend to look at three key symptoms, right? When we're working people up, we always look for a positive family history. We're always looking at positive labs, and we're looking at a positive physical exam. And so all of those components really would support a diagnosis of XLH and capture a family history. I know anecdotally that once we have diagnosed one patient, it's very clear that you will be able to impact an entire family. Diagnosing one patient can often lead to diagnosing multiples. In the past, we've had patients where they've diagnosed one, and I end up with 28 family members that are
Wow.
also affected by the condition.
Yeah. I mean, it's obviously it's like, these things, when we're talking to our patients. So, obviously, like I'm hearing, if patients early onset osteoarthritis, like, again, that's something that I hadn't really quite thought about this, obviously this bowed leg condition and, shorter stature, again, chronic musculoskeletal pain, that maybe isn't responding how we think, I think also too, the challenge would be when people have more than one thing, which a lot of our patients do, it's like they don't maybe just have ankylosing spondylitis or whatever. And so maybe even considering it in patients that, at least I think, maybe that have both things. Like, I've had a patient that has, I could think off the top of my head that has, a spondyloarthropathy, but also has, kind of other things where I'm like, I don't know exactly what's going on here. And so I think, important that we at least recognize this and be able to say, hey, quickly check this fasting phosphorus to see if there's maybe a link there. So on that same note, what are the essential lab tests and imaging studies that should be ordered when XLH is suspected? And are there pitfalls when you actually are looking at these results?
I would say just starting with a serum of fasting serum phosphorus, like we just talked about, but also looking at other bone markers and the other bone minerals, right? So working up the calcium and the vitamin D, as well as the active vitamin D, which sometimes gets left to nephrologists or whatever to check a 125, and then also checking an alkaline phosphatase because that can be a marker of rickets and osteomalacia in adults if suspecting XLH. And then finally, imaging can also be really helpful for looking for that evidence of rickets that you may not be able to see, if there's a lack of deformities. And it helps identify fractures and pseudofractures in the adult. But for pitfalls, I would say the biggest pitfall is just not including a phosphorus in our standard lab panels. It's not part of our comprehensive metabolic panel or our basic metabolic panel. And so it's really left to people to have accidentally leave it off of their labs. And then additionally, those phosphorus results can be affected by dietary phosphorus because phosphorus is in so many of the foods we eat. Most of the time, they're going to be protein sources. So ideally, not obtaining labs the correct way, not having it be a fasting level. And then finally, because that serum phosphorus level can vary over the lifespan, being careful that that age specific number, the age specific result is appropriate.
So I've already learned so much from you. And again, I didn't even realize I was supposed to have the patient fasting when they did the phosphorus level. So again, this will help me in my clinic, even tomorrow. How do you feel like rheumatology APPs can navigate this diagnostic process for XLH?
So I think just adding a serum phosphorus to the lab orders, if you're going to be evaluating the bone health of the patient, which is anybody who comes in with bone pain should get evaluated. Just as that as step one is really going to be beneficial. But then also there's genetic testing that can help accurately diagnose patients with XLH because they're looking for that FEX variant that we talked about at the beginning. And then in my opinion, I think that rooms are really well equipped to manage these patients with XLH. And you can learn more about the disease at a very specific XLH link HCP website. That's a wealth of knowledge.
Awesome. And I even think too, like a patient that maybe is fracturing at a young age, or because sometimes we get those consults, and an earlier osteoporosis where you're like, this really doesn't make sense. I think is important as we kind of think about what are some of the other reasons why we potentially should order this. And to your point, it seems pretty easy, at least the initial step, right? Like ordering the phosphorus fasting, I think is an easy thing that most of us have the ability to do, and then, kind of from there determining, okay, the phosphorus level is, low. Now what? Now what do we do? And so once this is diagnosed, what are the key components of its management?
So the management team can include rheumatologists alongside metabolic bone specialists, endocrinologists, nephrologists, orthopedic surgeons, and dentists. We're even including dentists in that multidisciplinary team because dentists are even seeing the effects of the disease with recurrent dental infections and the need for early root canals and stuff. So it's really, really interesting. And we're expanding the treatment for the condition across multiple different disciplinaries because, like I said, the condition is so diverse. And because phosphorus has its footprint in all these different systems in our bodies, that really so many different specialists can actually pick up on the diagnosis, which is really extraordinary when you think about this condition versus another one like HPP or like ankylosing spondylitis, where it's really limited to rheumatology. But the management of XLH is going to really depend on the severity of the patient's clinical presentation. So some ways to help with XLH will include, but of course not limited to medications and supplements. Some will require orthopedic interventions or surgery. And obviously, as rheumatologists, we're very well versed in physical therapy, but dental care is going to be very important. Genetic counseling is often always included in the treatment or the diagnosis, and then treatment for the hearing loss that we have seen, as well as preventing any complications. And then, of course, support for the patient, whether they work or go to school, because this condition is associated with really significant bone pain. That is often really, really tough to work through and to live through. This condition may not be life threatening, but it is definitely life altering. And then remembering that multidisciplinary care doesn't stop at any point, that there needs to be transition from peds to adult, and with age appropriate management, of course.
What do you see as the role, and you kind of alluded to this too, but what do you see as the role of rheum APPs in this kind of long-term management of XLH?
I think that as rheumatology APPs, we are so, so well qualified to diagnose and manage this condition. There's a saying, right, that we have to be twice as good for half the pay. And so I feel like as APPs, we are so good at listening to patients, really being persistent. And as rheumatologists, I think of us as detectives. And when we are never afraid to go back and re examine the patient and what they're presenting with and what their labs are. And I don't think that we ever stop until we know that we've done a good job and that we've taken care of the patient. So I think that as APPs, specifically in rheumatology, we are expert observers and we catch subtle symptoms, and we're really good at caring for patients in a longitudinal chronic disease. And that's why I think that we are the perfect providers for patients with XLH.
So, one thing that, I'm trying to wrap my brain around this and thinking about like, okay, what do I do? And again, to your point, we're such good, I think, diagnosticians. And I think we put all the pieces of the puzzle together. So I have a patient that is, maybe not responding, or, really basically kind of what you're suggesting, kind of in your opinion, is it really should just be kind of our standard workup for people that have chronic musculoskeletal pain. And so if we're thinking about ordering this, baseline phosphorus, not baseline, but if this fasting phosphorus and it's low, what then do we do? Like, what's the next step? So, okay, you have a low phosphorus. Now what do I do with that?
So, there should be no reason for a low serum phosphorus, really. I mean, really, when you get down to it. And then that would be XLH. But after that, then you can go one of two ways. We can go and check for that FEX variant with genetic testing to confirm the diagnosis. We can also do an FGF23, that hormone we also discussed at the beginning. But then there is a wealth of knowledge on that XLH Link HCP website that we talked about. But again, if I could go and say one thing to improve their ability, any rheumatology APP's ability to recognize and manage the XLH, it would be to get that fasting serum phosphorus, just like you said.
Yep. And so then after that, we see that it's low. And to your point, it should never be low. And then we have to kind of say, do we want to do the genetic testing? Or at this point, do we want to maybe, refer them to, a metabolic bone specialist, or, for them to do the additional studies? But obviously putting them on the road to getting the correct diagnosis, all of the things that, we need to have strong bones in order to live long, healthy lives and be strong. And so, absolutely. I think this should definitely be something that we look at and think about in our patients, and understanding that maybe we're not, I personally do not consider myself to be like an expert metabolic bone specialist, but it's more like understanding what to do, what to order, and then getting them on the right trajectory. And what you said, it sounds like within a multidisciplinary approach, right? Because you mentioned other specialists that maybe should be involved, but we can help to manage this condition, right?
Absolutely. Absolutely. I feel like it's far easier to take care of these patients than some of my even less complicated lupus patients. So I know that rheumatology APPs are the perfect people, perfect clinicians to take care of it.
Well, again, thank you so much for all your insights. Do you have any other closing thoughts for our listeners? This has been so wonderful. I know for me personally, so I'm sure it will help a lot of our listeners out there too.
I think that after you find your first patient with XLH, you'll want to find another. And knowing that you can have a positive impact on patients with XLH, you can find one, but you'll be able to impact an entire family possibly.
Oh, wow. Well, I don't know. It makes me kind of excited. I don't know if that's the right word,
Yeah.
but it's like when you make your first RA diagnosis or first lupus diagnosis. Again, not that you want these things for your patients, but just like there's with RA and lupus and all of our spondyloarthropathies, all these things, you completely change their lives. And after 18 years, if I've had $1 for every time someone told me that I saved their life, I mean, it's remarkable. And this is just something else that we can truly do to make an impact. So again, I think this was so helpful. And with that wraps up our episode today of the RhAPPcast. And again, thank you so much again for joining us for this really important discussion on XLH. Thank you, Bonnie, for being here. Again, I think this was so helpful to our listeners. And again, a special thank you to Kieran for their continued support of APP education. And if you're looking for more short form education on XLH and other rheumatic conditions, be sure to check out the content room on rhap.org, where we offer concise, high-yield learning to keep you informed and up to date. Also, please subscribe to RhAPPcast and share this episode with your colleagues. Thanks for listening, and we will see you next time.